Hello, everyone, and welcome back to the Hoporenkv podcast. My name is Crystal Cedino, and I am the Training and Development Manager for the Native Learning Center. With me today is my right-hand lady, Cora.
Hello, everybody. I'm Cora Anthony. I'm the Training and Development Specialist.
Thank you. And today we're very excited to have, we have a handful of guest speakers today, which is, I wouldn't say unusual, but definitely really cool to have this many people on one episode. So with that, I'm just going to kind of try and glide through all of these individuals that you see here on the screen or that you're going to hear momentarily. But we have Bart Garber, Director of Business Planning, and he's Board of Directors for Indigenous Pact. Bart, go ahead and say hi.
Hello, everyone. Glad to be here.
Thank you. And then we also have Don M. Coley, who's the VP, Healthcare Development, Tribal Relations. Hi, Don. Go ahead and say hi.
Hi.
Great.
Hello, everyone.
Wonderful. And then we have Ashley Heffy, who's VP of Policy. Go ahead and say hi.
Hello, all.
Wonderful. And then Julie Garrity, Health Policy Analyst.
Hi, everyone.
Great. Oh, it's so exciting to have all of you here today. So with that, today we are going to actually be discussing federal issues that relate to health equity in Indian country. Very excited to be moving forward in this topic because we definitely know that there is a gap and issue within here. So let's go ahead and just kind of dive in. So with that, tell us a bit more about each of your roles at Indigenous Pact and what drew you to the mission of IP. Anyone?
Okay, well, I'll just jump in. Again, this is Ashley Hesse, VP of Policy. You know, and honestly, this is one of these opportunities that I have, well, kind of dreamt about for a vast majority of my life. And I had the opportunity to cross paths with our CEO and founder, Kurt Brinkus, and he really sort of shared his vision for bringing about health equity in one generation for American Indians and Alaskan Natives. And at the time, I was working for the state of Wisconsin on a tribal initiative, a federal grant, a demonstration project to expand long-term care services. And while that was very significant and meaningful work, I heard his sort of moonshot mission, if you will. And I thought, wow, that is like speaks so to my heart. And I just remember sitting down at an introduction meeting and lunch or breakfast, whatever it may be, and just telling them, I will do anything. If you have an office space, I'll sweep your floors. If you have windows or things to be dust or furniture, I will move. I will do anything because I believe so strongly in what was this vision and this mission. And really, it and a lot of door knocking, I just kept coming back around and around, and eventually got my foot in the door and have been with the company for almost 4 years now. And we've just been growing. And I will just say that it really is truly an opportunity, a dream, and a true honor to be a part of this team. And I can kind of leave it at that.
Great. Dawn or Julie or Bart, feel free to jump in.
Well, hi, this is Dawn Coley, and I've spent the last 4 decades working with American Indian Alaska Native communities and in healthcare administration. And I met Kurt 2 years ago at a conference, and he was just so dynamic, and his approach and all of his ideas of working with the tribes and communities really resonated with me. And I love getting up every day and being able to, provide outreach, education, resources to these communities. And he's just been such a wealth of information going into this next journey of my career. So I'm so delighted to be a part of this team. We really have, very talented members that work at Indigenous Pact. So I'm blessed. And this is, like I said, it's been 4 decades. So here we are today.
Thank you. Bart and Julie, go ahead, either one of you.
Hi, this is Julie Garrity. I work on the policy team with Ashley. So the way I found IP was I graduated law school in the middle of 2020, so right as the pandemic was raging on. And all my experience in law school, I worked mostly on legislative research and advocacy. So a little different than your traditional litigation path that you see for most law students. But when I graduated, I really wanted to find a place that served addressing different healthcare inequity issues because I had specialized in healthcare law in school. I stumbled upon IP just by luck. I applied immediately because this is what I've always wanted to do. I want to make healthcare more accessible for people who really need it. And then I met Ashley and Dawn through the next few weeks and absolutely fell in love with the mission. And I've been on board for 4 to 6 months now, and I would say it's been the most fantastic experience. And I'm so lucky to be on this team.
Wonderful. Thank you so much. And Bart, your turn.
Thank you. Well, Dawn is from Maine, and I'm from the other end of the country in Alaska. And I ran into Kurt indirectly through a old political friend of mine in Alaska when they were trying to bring some of Kurt's opportunities to our state. I met him, helped him around some of the tribes there, my own in Tyonek, as well as some of the city-based organizations, and got to know him and at least the early beginnings of Indigenous Pact. Now, my background is, with all due respect to Dawn, I'm probably the oldest one in the group here, and have been an attorney for about 40 years and running businesses, tribal businesses, as well as healthcare organizations for over 20, 25 years. And that's nationwide. I serve on a Navajo board, business development board, so I'm familiar with issues in Alaska as well as across the country, and had an opportunity to teach and head of some university programs. So I have kind of an academic background, but then a practical on the ground background as well. And have been able to, at this stage in my career, have that real joy of being able to take everything that you've learned for so long and apply it to a very, I wouldn't say narrow set of issues, but very specific set of issues in tribal and native healthcare, and particularly with very sharp young people, including Dawn, who know the issues and can really address them very distinctly. And then Kurt with a broad vision of that mission, inspired by personal connections with his own children and stepchildren. We've made great advances in tribal health. We've got wonderful organizations nationwide, and we have a better opportunity than many of the other healthcare organizations around to really have universal solutions to healthcare. But we struggle with resources. We struggle with having to run organizations with relatively few people, with large numbers of complex organizations, while at the same time battling national, statewide, and local healthcare issues. So it's like you're on 5 fronts all at once. It's the perfect opportunity for an organization like Indigenous Pact to come in and provide additional resources, to focus the ones that are there and find additional resources, and have a very, very specific mission to create equity and to create broader opportunities to obtain healthcare. The tribal healthcare system in the United States has a long ways to go. We have lots of opportunities, and it's the right time for an organization like Indigenous Pact, and I'm very happy to be working here.
Well, we are very excited to have all of you here. So thank you so much for introducing yourself and telling us a little bit more. Definitely appreciate this. And I think this is, one of the wonderful things about the Native Learning Center. Sounds like a lot of you have fallen into your roles and whatnot. And I can definitely say the same for Cora and myself. I actually started off as a receptionist and then fell in love with what we were doing, and then kind of just made my way up. And then Cora was looking for, something else within the tribe, and she just so happened to have everything I needed to, move forward with all the projects, I wanted to accomplish this year. So definitely we are with you on that. But I believe Cora has a question for all of you on our next one.
Yes, I heard you kind of mention on all the front lines, right? State, local, and national. So I guess I'm curious about the work that Indigenous Pact does when it comes to federal guidelines and federal statutes, what is your role? How do you kind of bridge that gap for our tribal communities?
Yeah, I can just start there because I realized maybe I left a little bit of information out as well. You know, as head of policy, a big part of my role that I see is just to continue to be that eye in the sky, if you will, and continually surveying the landscape that is always moving and shifting when it comes to federal policies and rules and regs. Some seem pretty entrenched and stuck and sort of stayed, but there's a lot of nuanced movements and a lot of political action at the national level. And so I try to at least tune in and, you know, pay attention to those things that seem most relevant to the day and opportunities that might present themselves through funding, even though, that's an approach. But really, for my role, I will, again, sort of this overview and oversight to look for, niche opportunities and look for that gray area. And Julie, you can speak, and Bart and others. I'm not a lawyer. I don't have that legal background, but I can read between the lines very well. And there's so much gray, and there's often opportunity within that gray space to bring about innovative ideas and solutions. So I would say, from my perspective and role is really, I like to look at a lot of just broad areas and then try to target in, whether it's, I've seen things on broadband and housing. We can get into some of the details, but that's a big part of what I do is really survey and look for opportunities and then work with others in our team here to find out, okay, what is the maximal opportunity that we have to bring about some significant change and impact in moving the needle on health equity for the different, tribal partners that we're asked to support. And yeah, I'll leave it to there. But I do, Julie is a great resource, and I'm super excited to have her on our team as well, because she fills in a really important role for me in some of the detailed work.
Yeah, absolutely. I feel very lucky to, again, be working with Ashley, but also the way that the Indigenous Pact teams work collaboratively. So with Dawn, for example, Dawn will be more of a boots on the ground front, and she can tell us, what the problems are, what she's seeing out there in various places, things that need to be addressed. And then Ashley and I talk about it, and we're like, okay, well, maybe we need to research how federally qualified health centers are run. What is the policy going on in Medicare right now? Has any state been able to fix this on their own? Have the feds sort of stood in the way of that? Where are we now? So that's sort of where I'll dive in, and I'll do more research on these specific problems that our business development team finds. And then we do things like 50 state surveys to see where, all the legislation is, how much success people have had with the feds. And then our end goal is to just modernize policy so that, we can get whatever problems out of the way, see if we can make things more efficient, have better health outcomes for tribal populations and tribal members. So that's our end goal, and that's sort of how we go about making it happen.
Thank you for sharing that, for sure. You're talking about kind of like how you see what's going on and the policies and kind of how you work through that. Can you tell us about some agencies that Indigenous Pact has worked with or that you track to support tribal communities?
Yes, we can give you a specific reference right now. It's a little bit of the nature that Indigenous Pact is 3 years old officially, I think. So, it's early in its nascent life here. Our issues arise from the bottom, from an individual tribe saying they need help on something, to way up at the very top at Health Human Services, CMS, and we understand that there's some national policy that we have to get through in order to be able to resolve something way down at the bottom or somewhere in the middle. So we work with CMS in the offices in Maryland who do a number of things. They oversee opioid treatment clinics. They oversee Medicaid, Medicare plans and the payments and systems for implementing those programs. And those are very important to many of our clients in terms of getting reimbursements and how they get reimbursed. And they have policies that go out nationally that impact individual tribes on a case-by-case basis, state by state. And I hate to tell you this, but it's random. There are some states that adopt a CMS program to be able to take on a particular kind of billing matrix, and others that don't. And even those that do have 5 different ways of doing it. So that even though you say there's an Indian healthcare program and there's a tribal healthcare program, it changes depending on where you are and what the issue is. And that impacts our particular clients in being able to recover for services that they provide is really technically on the ground. And it kind of outlines really the broad issues in Indian healthcare. Right now, the major players are IHS, the tribal healthcare contractors, whether they take on single contracts or large facilities, and I hate to tell you this, but lawyers. Because the major players, whenever you're in IHS program negotiations or anything, is not some consultant, it's a lawyer. And frankly, they're good at it. There are some major firms that specializes in Indian healthcare, and they are the primary guiders and resolvers of problems, recovering unrecovered, indirect costs that weren't being paid simply because the IHS says, well, we can't. The law says that you shall, but they say we can't. The lawyers come in and the judges say you will. So, that's one way of resolving an issue, but that's not very efficient. One lawsuit after another. You never get ahead of the game. There's always a problem arising, and litigation isn't always the best resolution. There are a number of smaller and more specific healthcare consultants and contractors, and then there's also the 4th level, which is representatives of all of these. And Dawn can really speak to that with the Indian Health Board, with NIH. Some of them are Indian specific, some of them are national. Natives get caught up in individual Native issues and national public health issues and everything in between. Indigenous Pact, in this case, is working with CMS, Centers for Medicaid and Medicare Services, to try to resolve billing issues in particular states and see if we can't get preferential outcomes. They're in the middle of reviewing a policy that they came up with that sounded like a real conservative bad policy in the end of a liberal administration. And now they're trying to explain themselves and fix it because for some odd reason or they thought it was a good idea to reduce the ability for tribes to recover the payment for their services, or at least make it more difficult. And we're trying to resolve that right now, and they're in the middle of that. So that's one specific one. But Dawn, maybe you can talk about more of the national and specific issues, because Dawn is involved with particular contracts, but then has 40 years of experience at the highest policy levels.
Thank you, Bart. So through my experience in working with the national Indian organizations in Washington, D.C., preferably the National Indian Health Board, we really were looking to empower American Indian Alaska Native people and to protect, improve the health and reduce health disparities within the tribal nations. The National Indian Health Board has, been here for over 40 years, and the tribes, were instrumental in really advocating to form this National Health Board, which would help advocate to the U.S. Congress, Indian Health Services, and other federal agencies, even private foundations, about the health disparities, the public health issues that were all experienced in Indian country. So through all of the federal trust responsibilities, that the federal government works with the tribal nations for advancement in their health programs or education, these Indian organizations, national Indian organizations in DC, have led the charge and really looked for advocacy, legislation, and developing policies to lead these national programs. As Bart mentioned, part of the disconnect can be, being at the boots on the ground or in the community level. It's, wonderful to have these national organizations overarching that represent, the 12 geographic service areas for opportunities in the advancement of American Indian Alaska Native healthcare. But when you start getting into these communities, the tribal communities, and you start uncovering some of these issues, that they're still experiencing, 50 or 60 years later after the formation of the Indian Health Services or some of these federal agencies, it's just really daunting. And again, this is where our Indigenous Pact and our business development team come together and work with these communities. And at the intersection of all of this federal policy, these national organizations and the community development areas.
Yeah, and I just want to jump in there. And Dawn and Bart, you mentioned it. Really, this is all grounded in this our federal, recognized tribes and the federal government and this government to government relationship. And Bart was sort of talking a little about, how you have to work, at the highest levels, and then Dawn's talking we're right there in the communities working with program directors or tribal leadership or whoever to figure out what the issue is and how to resolve a problem. But all of this is really grounded in our treaties, laws, Supreme Court cases, executive orders, and even the Constitution really recognizes the rights of our tribal nations as sovereigns, and they have a right to govern themselves. We have a right to our land and resources and how they fit. And Bart was sort of touching on it, just even the right to get paid for the services you provide to both tribal members and maybe non-tribal members, if that's your decision and choice, depending on the capacity. We have a right to recover those fees and the costs and the services, and it can get so tangled up, starting from the federal rules. Well, there's a lot of room there because we have that federal state, balance as well that they try to keep in there. And so when states have room to interpret what the federal rules and regs say, we get kind of caught in that mix. Well, then the tribes, we have this view of it too. And then so we get in this process of, just challenging things. And like Bartlett, it could end up in courts. It could be in congressional hearings, as Dawn was noting. We have this ongoing advocacy at national levels, at local levels. And, this is really just kind of want to acknowledge that reality and this long-standing history of, we have an Indian Health Service, and yes, we're supposed to be moving in, this direction. And yes, the feds are telling tribes you need to tap into third-party recoveries, and you need to start running your health centers like businesses. And there's so much movement all the time. When we're asked to support, a tribe in whatever their initiative is to be more self-determined and to create that vision for themselves and their people, we are really flexible, I think, and have a broad set of capabilities collectively to really focus on those areas that there's a need for increased capacity. We can really support tribes in so many different ways. We're focusing on a lot of policy and legislative discussion here. And that's a big thing. Those are usually really large rocks to move. And the tribe may or may not be directly engaged with that activity or effort. They're, depending on who we're speaking to, they may or may not be aware of what some of the other larger national discussions are. So we're able to kind of bring a real good perspective of where things are currently at, maybe with some political actions, where some of the funding streams are coming in and how to maximize those opportunities. But we're really trying to find long-term solutions and, to break out of this cycle that we seem to continually get caught in of funding, coming in, then it's shortfall. It's never enough to really launch a new initiative. It's hardly enough to really meet the needs and the healthcare needs of our current members, on reservation, much less off-res or territory, and living in our urban environments or our more rural areas. And really, we're Indians, we're everywhere. And, to provide healthcare and say we have an Indian Health Service. Well, it's now advanced, we have our IHS service, our tribal programs through Contractor Compact, and our urban Indian programs are finally getting a little love these days and recognition after a long decade plus, I'm sure, of efforts of advocacy, trying to just get recognized that they're providing a great level of service to urban natives and folks in the cities that have been, pushed there historically. There's so many things we could talk about in the past that have gotten us here, but like Bart had noted earlier, it's very, from the top to the bottom, there's so much work that needs to be done, and Dawn was talking about that as well. I mean, that's really what I'd say we're experts at. We are really quite capable of coming in and helping to untangle what is, giving some clarity as to what potential directions and opportunities you have, what's most feasible for sustainable operations in a healthcare program to meet that vision. And we can also help develop visions and dreams. Like, I might have a vision of what could be, but it's only based on what I'm aware of. Dawn could come in and create a bigger, clear view of the universe for me. I'm like, now my vision has grown, but I'm still only able to do this. So Indigenous Pact is really there to kind of help increase that capacity and to meet the vision and the needs for the tribe and when it comes to the healthcare arena.
No, I love that. And I was just going to say, because all of this sounds so like it can be over everyone's heads, because, if you're not in it and you're not so familiar with it, then you're lost. You have no idea where to navigate through or anything along those lines. So it's really nice to see the faces kind of behind, the scenes that are doing that digging for you and trying to help that untanglement and just better understand how you can, like you said, depending on what your community wants to accomplish or, organization wants to accomplish, you guys are kind of there to help guide that, which is really nice, because I'm pretty sure we can all agree that within Indian country, a lot of the time we're left out of the conversation and we have no clue where to move forward or who to contact or anything along those lines. So absolutely. But with that, because we are talking about federal legislation, so on and so forth, what are some of the federal legislations that directly impact Indian country? And does IP work with these? And if so, to what capacities? I know we mentioned already, we're kind of like all the way up here and all the way down here, but is there anything else that you guys can shed light on about that?
Ashley, why don't you mention some of the DEA and some of the CMS changes that have occurred, especially with regard to mobile medicine?
Yeah, so one of the areas, thanks, Bart, one of the areas we've been tracking for some time, it's around, it's part of this opioid epidemic that our country has been facing for just far too long, and we've been watching this wave come, and we're in it, and we're in it deep. And so, been watching for a long time, some interesting actions that the DEA had introduced. They in July of this year yet, their final rule around mobile narcotic treatment programs, or mobile units as they'll call them, or there's medication units, SAMHSA calls them mobile medication units. So it was a piece that was years in the making. It was like years and years and years. They put out their notice of proposed rulemaking changes around these mobile units. It was like 3 years. They received comment, and then they took forever to get through it. And then they finally issued a final rule saying, okay, these mobile narcotic treatment programs can, you can operate them. It was piloted for some period of time. It was just like agreements between the DEA and specific opioid treatment programs that were allowed to use these things. But now it just sort of opened the door for, nationwide, for opioid treatment programs to enlist the, support, or to create a program of mobile units to get out of the brick and mortar, and, to get out of like this, you have to come here for your medications. And, really trying to expand. There's lots of people that are not getting the accurate or the appropriate recovery and treatment services. So that was just one thing. It took years to follow where that rule was. And then once the rule was in place, now we can act. But then what you get stuck with is SAMHSA wasn't quite ready, and they're the regulatory body that oversees these opioid treatment programs. They had to figure out, well, okay, what are we going to do to change our accreditation processes or practices, if anything, and our regulations, what needs to change? And then you have to be accredited. So you have national accrediting bodies. And then how do they respond to these changes? And then you have to work with the states. It's like, that's where it really gets down to it. Like, well, how is the state set up in their Medicaid programs, in their systems for behavioral health, to provide for opioid treatment care? So that was just an interesting one to see. And then, really, are the states able to license these and certify these? So, and they're trying to figure out how to get caught up with it. So we're right in the middle of that, and we found some really great solutions and are moving forward with a couple of tribal partners in initiating these particular mobile narcotic treatment programs. But I mean, that's just one piece of, and this is really part of that, the Support Act and much broader federal initiatives to combat this opioid epidemic, you know, so.
It's another one that is, a lot of Native issues end up becoming pan-Indian and national. One is in managed care. Managed care organizations have been a common thread in the United States and urban communities for some time, where large, basically insurance type companies manage Medicaid payments within a state under contract with a state. Tribes and Native people have been thrown into those indirectly whenever they were Medicaid recipients. But a few years ago, someone who was pretty crafty and thinking ahead slipped an amendment in, which frequently happens in Indian legislation, allowing tribes to form Indian managed care organizations. And this would, and in tribes, there's frequently a very high percentage of people on a reservation who are Medicaid eligible. And so you have all of these Medicaid payments being made to tribal organizations because the Medicaid payments get paid to the tribal contractors or IHS facilities, and they're being managed by a non-Native organization out in the city somewhere. And the services that they provide may simply be minimal or, you know, determined somewhere else rather than through the view or through the lens of a tribal person and what kind of healthcare they need. So there was the notion that, hey, maybe tribes or tribal organizations could form their own Indian managed care organizations. And there weren't any up until about a year ago. And then suddenly there's been sort of a rush to the bar to try to see if they couldn't get some of these done. Now, this sort of reflects the tribal community itself. You know, we've been talking about like maybe this is just one whole big, you know, 40 varieties of vanilla tribal organizations, but that's not the case. You know, up in Alaska, you've got tribal healthcare organizations with 2,500 employees, $250 million budgets. And then you're talking about other places where I know one in particular where there's 12 employees and the 3 semi-physicians are really specialists are all contractors. And, you know, little tiny organization. We work with both ends of the spectrum. I've been on the board at Navajo where we've been attempting to get the very first fairly significant Indian managed care organization off the ground and run into political issues. But the need is there. We're just dealing with New Mexico alone. There's potentially 75,000 Navajo beneficiaries for a Medicaid Indian managed care organization. If we went to Arizona, it's twice that. You're talking about billions of dollars of reimbursable fees that could be managed by the tribe and by tribal people. We have been recently engaged, or at least we've been talked to by a small tribe that actually may have one of the very first actual Indian managed care organizations just to deal with their own tribal people, which is a handful of thousands of people in a kind of non-traditional Native location, at least what we think of that in the East Coast. And that will be a very interesting experience because this provides one more level of tribal healthcare sovereignty, and that is not just managing your healthcare, but managing the resources for your healthcare. In this case, Medicaid payments through an Indian managed care organization. So we're involved with that at all levels, at policy. I mean, I'm on the board of another organization where, you know, we're doing the arm wrestling and leg wrestling, and here pretty soon we'll be advising a small group.
And, you know, Bart, you bring up a really interesting point to me. The American Recovery and Reinvestment Act of 2009 really kind of put out some of the rules of the road, Section 5006, if you will, for the ITU Medicaid provisions and cost sharing rules and, you know, everything that relates to these managed care, Medicaid managed care rules. And then tribes are really, we have to engage, you know, in that arena. And when we talk about managed care organizations, I mean, just within there, you have a MCO proper, a full risk-based managed care organization. You have prepaid inpatient health plan model you could use. You could have a prepaid ambulatory health plan you could set up and operate, or you have a primary care case management kind of a model. So there's like 4 different models of potential Indian managed care entities, and they all have their own, you know, just risks and requirements that you need to meet before you can even be eligible to that. So just because the federal law says, hey, tribes, you can do this, well, there's a lot that goes into it. And what we're seeing is a lot of the tribes, where if they talk about an Indian managed care entity, those handful of tribes that are moving in that direction. In some states like Oregon are, for example, are kind of really helping to shepherd that along. They're really focusing on a primary care case management model and is their Indian managed care entity type. And that's just fine, and that's great, you know, but it's a starting point. You know, you start to manage the care. Who's making the determinations over, you know, what service so-and-so is going to get, and at what frequency, and for how long, and at what rate. You know, states are shifting so much of their responsibility. The feds will lay the framework. States respond with their Medicaid systems and are pushing for decades now, offloading so much of this to these other entities, the non-governmental entities, private corporations, or national, they're regional, but these managed care, Medicaid managed care entities. And it just creates this whole other layer of complexity to untangle. And then as tribal health systems and programs, if you're just trying to get reimbursed at an appropriate rate, at the OMB rate, or all-inclusive rate that we're entitled to, it just gets really messy, you know, as far as who's paying who and at what rate. And again, this is one of those areas that I just get excited about. And I love to dig in and like, all right, well, how can we figure this out? Because we have a right to get paid. End of the story, you know, because there's a mission here. We need to become far more self-determined in our health care provisions. And I think that is the mission, that, you know, bring about those realities for our tribal partners.
And all that sounds nice and sexy and romantic, but the real problem is you could get paid within 15 to 20 days from the state. When it goes to a managed care organization, you're suddenly out 90
or 180. Yeah.
That's great.
I mean, to the point where you could almost lose your reimbursements if you forgot about it.
Right.
So there are real practical problems that come up at each stage. It's just a real mess.
No, absolutely. It's funny, Ashley, you're mentioning OMB, and you're giving me flashbacks to our our compliance and resource development director. He totally, and he'll appreciate this, geeks out on OMB regulations and so on and so forth. So he gets probably just excited about it as you do. So it was just funny to hear you say that. I was like, oh, Vince. All right. Go ahead, Cora.
No, I'm just so thankful that there's organizations like Indigenous Pact out there to provide the support that these communities need, because like Crystal mentioned earlier, this is a lot, and navigating through it and knowing all the policies and knowing all the intricacies of who I have to go to, what do I have to file, how do I get my reimbursements back? It can be overwhelming for our communities that might not be well versed. So thank you guys for putting in the work, for creating such a great organization where our underserved communities can have that support, right? And so I kind of want to piggyback off what Bart said, and said that's all nice and romantic and whatnot. So, but let's get to the nitty gritty. What do you guys think are or see as some of the hot button issues in this upcoming year?
Well, you know, I appreciate it, and if others have their opinions and thoughts too, because what I see as hot button issues, you know, I will just acknowledge it is my opinion and my perspective. But one of the things that I'm truly passionate about, and I really see it's both ends of our spectrum. It's our elders and it's our youth, and it's not to be forgetting everybody in between doing the work. But for me right now, the opioid epidemic continues to hit everyone. I mean, it's full spectrum, whether you're directly impacted through an addiction or it's your family and friends around you. I mean, this has been continually devastating. So to me, this is just an ongoing area that we need to dig into, which is why I'm super excited about the opioid treatment program work. We get to do the mobile narcotic treatment, you know, regulations, and trying to, you know, work on a full spectrum from the office-based, you know, outpatient, you know, OBOTs to OTPs, like a full spectrum from harm reduction, no barrier access to, you know, full out recovery, support services as long as necessary, and hopefully we launch you into a different stage of life, so like that is an area that I see is just, it's not going away, and we cannot give enough focus to that, in my opinion. But and it goes right to the elder side. I mean, this past year, Medicare has put in provisions for they pay for opioid treatment programs for our elders. It's like, well, if that doesn't start to speak to some of the issues of prescription and over prescribing and just the challenges that our elders can get into, and our caregivers trying to help manage that, which goes into whole other tracks. But just strictly with the elder side, home and community-based services. This is an area that is just ready for attention, and it's just been screaming for help for so long. The in-home care and services to let our elders remain in our communities, in home, and age in place for as long as possible, and our disabled relatives, our brothers and sisters, who there is no federal funding. There's no line item funding directly to address the needs of our disabled relatives, whether it's through birth or accident, illness, injury, or age-related infirmities. It matters not. There's no federal funding to support the needs of our disabled and our elderly people. And that to me is just one of these things that it's huge on this coming year, because it touches on such a broad spectrum of needs. I just look at disability services and the home and community and our opiate epidemic are two things that cut across all demographics, and those are areas that there's so much depth and breadth to them that I'll stop there. But that for me are some key focus areas, and others might have opinions too, but please.
Yeah, Carl, this is Bart. As usual, Ashley, has the very sharp spear. I have the club. I do believe that on a broader basis, access is going to become an issue. Access, not the way we've described it, Indigenous Pact up to now, but access as we know it now. With COVID and understanding that COVID is not going to go away. COVID is going to be a way of life. And it has become difficult for people to get into hospitals or feel safe in hospitals or healthcare facilities. And it's always been a problem for Native communities. And it's both a problem and an opportunity, because if anyone who comes from a Native community knows that the hospital is also a social gathering place, which is an irony, because that's where, disease and illness and all kinds of things exist. But that's where people say hi and, talk to each other. But on places like Navajo, it's difficult to get there, and the facilities are far apart, and much less the fact if you live in town or if you commute off your reservation to go somewhere else and live a ways away. IHS and tribal services are terribly geographic oriented, and they've been good. They started that way historically from a place, but they become a limitation, which is why I do believe that some of the very specific acceptances of mobile dosing for opioids and stuff might be able to be expanded. I know that in Navajo, they already have some kind, and many tribes have transportation programs. Most of them are busing and things like this, and maybe sometimes mobile clinics or site visits to small clinics by specialists. But I do believe that that's going to become more of a focus because of these access and because of these external threats that you have to adjust to, because it's a little bit easier to take care of somebody in one place and minimize the threat of transmission and things like these. So I do believe that that's going to become an issue, and it's going to kind of link with some of these mobile healthcare solutions and the like. And, this is where, Crystal, you mentioned a word that I think we should take up a little bit more at Indigenous Pact, and that is that we are navigators. And we might literally become navigators with our healthcare mobile networks. But we also have, if you didn't know, we have a profit side, which is Indigenous Pact Public Benefit Corporation. And then we have a foundation, the Indigenous Pact Foundation, which is looking to start funding more public health, Indian issues, long-term research issues. We're putting together some databases that will be useful to our clients there, and then using a lot of that information to address programs on our actual action side, so that Indigenous Pact will become a navigator in many respects, both with respect to helping specific clients, as well as providing a database and a resource that you can kind of piece it together with various organizations, but I'm not aware that it's in any one place. And so I hope that we can do that a little bit more into the future.
Absolutely. Oh, all the points that both of you have made so far as far as hot buttons, one of which I've experienced myself in my own family. So, and then I've gone to see, we've had the privilege of, going out to these communities and really understanding, the issue of distance, to, these healthcare facilities. And, I'm really lucky. I grew up, in this environment where everything was kind of essentially hop skip away, and I know that is not the case for Indian country, for a lot of communities within Indian country. So I would really like to see that kind of like take off. Bart, I agree. I think that'll be incredibly beneficial for our communities. But any other hot buttons anyone wants to talk about while we're here?
Well, I guess just going off of what both Ashley and Bart said, it's pretty closely related, but I mean, there was no baton passed from the opioid epidemic to COVID. They're both, the opioid epidemic still exists. It's still a problem that really seriously affects Native American populations nationwide. So that's a lot of what we have chosen to focus on. And I do think that it's going to remain a hot button issue for a long time. And I think, like what Bart said, going to the hospital in particular, I know it was funny when he was bringing up how it's a social setting, a hospital. I know they tell transplant patients not to go to hospitals because they're immune suppressed and the best place to get sick is a hospital. So in particular with the COVID epidemic, people with disabilities don't have access to services they might have previously. So in turn, I think that a huge hot button issue is going to be telehealth services being expanded. I know there have, of course, been efforts to expand them since COVID started in particular, but I think that that's going to continue progressing, and I think it definitely needs to. The distance issue is a huge problem. Everything from, again, organ transplant patients to people going through the opioid epidemic to people in need of behavioral health services. I think that telehealth is definitely going to be a huge target for the future of healthcare. I think that it's so necessary, and it's just where we have to go. Hopefully next year we can make large improvements. That would be my personal goal, to help in any way I can. But I do think that that is something to definitely everyone should keep their eye on.
So I agree with everyone, and I just want to add that we also are, experiencing a shortage of healthcare workers. We're trying to push, vaccination programs, and I know several family members that have made appointments, to go for a vaccination, and the clinics are closed because the clinical staff do not want to be vaccinated. It's become a hot issue and a hot topic, and a lot of it's happening at these Indian Health Service clinics, hospital settings and situations. So I think that's really going to be a big issue. And telehealth, absolutely. That's one of the ways that we'll be able to kind of work through or navigate to help some of these individuals, get that quality of care or continuity of care. But the healthcare workforce is, really something that we need to, stay aware of.
That reminds me of the headlines. You all have seen it, where there are large numbers of healthcare workers leaving, or stop. They're ending their normal practice, and the only way they'll stay is by becoming contract nurses at 3 times the rate and stuff like that. And you can see it in the system. I was at just recently at a healthcare facility. I thought it was maybe one of the worst run IHS facilities I ever saw. And then I saw the sign outside. It's Walgreens. They're just having a struggle because Walgreens and CVS are doing all of the inoculations now. And both of them that I went to, it looked like a Three Stooges cartoon. There were just so many people there, and so many overworked people. And the one poor pharmacist is just sitting behind the counter, or behind the table there, doing the inoculations, and his assistants and clerical people are trying to keep up with things. Prescriptions are getting mixed up, all sorts of things. Just a general kind of network system that we have in this country is overtaxed much less talking about hours. So, we have to, it's not just finding workers, we have to create an environment that's going to be receptive to people. Otherwise, we'll never find the students unless we make it a preferred area to go work. So we have to go through some kind of a real program to, and you can't just do it with, Fifth Avenue or Madison Avenue advertising group. You actually have to get down and actually change the system so that it's something that people want to become involved with. And I think that that's maybe a larger struggle that, Dawn, the kind of people you've talked to in the Indian Health Board. I know that when I ran a mid-sized healthcare organization, one of the toughest jobs you have is recruiting. You're just constantly going out in the woods of Wyoming and Colorado to try to find a doctor who hasn't been, convicted of something. And it's just hard to do.
Yeah, absolutely, Bart. And one of the biggest challenges that we had in India country recruiting for physicians was housing, affordable housing and having that, near where the facility that they were going to be employed. And now it's, do they want to be vaccinated to work in that clinic? And then, so it's just exacerbated over the last, 2 years. So yes, we have the opioid epidemic, we have COVID, and then we have Indigenous Pact to help navigate or maybe find some resources for some of our clients that are coming to us that have these challenges. And this is part of the conversation, when our business development team, is contacted, we talk to the individuals within a tribal community, and, sometimes there may be a health assessment that's done, and that's a part of it, it's socio, it's economic, it's all tied together. And, so that's really, what we're seeing, and how Indigenous Pact is also, working with some of these communities is try to look for some of these resources or outcomes.
Thank you all for that. Yeah.
Yeah, I was just going to say, because we've talked about a lot of, the challenges that, exist and whatnot. So I kind of wanted to go on the other end of the spectrum and say, what are, some of the greater opportunities, within health equity in Indian country at maybe the federal level, if any of you can expand on that.
But again, housing is one of those primary drivers of, that we see, that we've heard it, it prevents, the ability to hire, I'm just thinking of people coming out of post, of rehab, coming out of a hospital, like where do you come back to, or you have, all our domestic violence matters, and you've got the overcrowding, you've got COVID, you've got, environmental health issues with asthma and other things. It's just like under quality, low quality housing, and just not enough housing stock. I mean, it's out there already in the dominant culture and everywhere else, but you look at Indian country and we know the stories, we don't even track homelessness, I mean, there's this like, there's so many issues, but yeah, housing, thank you. It's been a long-standing, like, it dogs me. That's a topic that I am constantly circling around. And again, it's one of these cross-cutting issues, that if we can start to, okay, we're starting to address some of the addiction, we're starting to address some of the healthcare access and quality of services and the reimbursements. But when we start to look at, like, okay, let's say we got a little more robust system, the money is flowing, our systems and operations are working well, the outcomes we're hoping to achieve are there. We need housing, and housing is healthcare. So when I look at health, housing is a form of healthcare and a means to bring about health equity and quality of life. And there's models that we're toying with and designing around, from permanent supportive housing and supportive housing, and how do you build in some of the clinical services right there in these facilities, to build these bridges, to how do you start designing campus more like housing communities, like more, thoughtful approaches to housing and community development, and aggregating our resources and being smarter in designing and developing that. We get some opportunities to engage in that space, but it's a true area. We have some expertise in well-spaced design and healing spaces. Not only we tend to apply it to our facilities and our health clinic kind of operations in our work, but I want to be able to bring that down to the housing side of things. Like, okay, we have the expertise of well-spaced design and healing spaces, and we know how to do that and how to make physical space a good space to be in. Let's apply that to housing models and design. And what are the resource gaps, you know, and the funding needs, and the planning, and there's just a lot of challenges in there. And I've had opportunities over the last few years working with different cohorts of tribal housing initiatives funded through NAHASDA grants or other, you know, HUD programs. But just trying to get that launched and maintaining a focus on the clinical needs sometimes, or the healthcare needs, and how to integrate that. It's an interesting space to be able to engage in, and that is something I would, very passionate about as well. So.
And it's not just an esoteric discussion on our part.
No.
I was making a big pitch, and after about 15 minutes with a chairman of a committee of the Navajo about addiction and addiction treatment, the first words out of his mouth were, "But how about housing?" And he, immediately that's what he recognizes as a problem, whether it's alcohol treatment, meth, cocaine, opioid. It's what do you do with the person once you fix them, because then they're just stuck, out on the street or whatever, because they've been, kind of run out of the community and the economy, and you have to reintegrate them. So it's a bigger system. The only other thing before we get too close to the end I wanted to mention is, the law firms do great work out there. Our national, local, statewide, sub-regional organizations have, I just can't believe how, the few, really speaking, the few Native healthcare representatives, Native and non-Native alike, participate in all of these things. They all do good work. But, we even despite me being a lawyer, we're not a law firm. We are a private consulting firm with multiple disciplinary people. We have high-level addiction doctors. We have high-level facility development people, Six Sigma process workers. We've got people who've managed healthcare organizations and inpatient and outpatient clinics, as well as everyone on the screen here and others. And so when you call on us, we're not going to talk to you about a legal solution. We're not going to be talking to you about some kind of policy potential solution. We're going to be talking about what it is your problem is and what type of skills are necessary to address it. And that doesn't exist other than in maybe the largest Native healthcare organizations that kind of develop that internally. And that's not really their main focus. Their main focus is to get things done, not to fix things. And so we not only fix them, but we try to foresee how to build them and how to make them better the next time around, learning from, the evolution of these things as they've come along. So I just wanted to throw that in, that there are more people than just on this screen, even though we're talking about federal issues.
No, like I said earlier before, I think not only the team that we have on the screen, but just the entire organization of Indigenous Pact, you guys are doing amazing work. And I fully agree with you in the terms that housing is much needed, because I've seen it firsthand where we rehabilitate people and then it's like, well, what now? And so it really kind of stumps them as to how do I keep moving forward in my process and in my growth when I can only go back to where I was, right? So no, again, I can't say it enough. Thank you for the work that you guys are doing. So do you guys have anything else you want to share with our listeners today in terms of the work that you guys do in relationship to the federal issues or whatnot? Any other caveats you want to get off of your chest? No?
There's just one vision that Kurt has presented to us, and Ashley was referring to it a little bit. The broader vision is that not only are we attempting to try to assist particular patients, particular clients that have issues of their own, but we're seeing if we can't looking at integrating the larger tribal and IHS healthcare system. It's a little, and this is where the business side of me comes out. I've been 30 years as a business person, and that there's been lots of companies that have integrated, individual businesses. Somebody's got a chiropractor office and they put 30 of them together nationwide. They create efficiencies and better services that way. Or, Sadly, your little mom and pop wholesale stores have now become Lowe's and Home Depot. We don't need to do that, but we can take on some of the practices. And we've got probably the most extensive healthcare network in the country for a particular group of people. And yet we do everything we possibly can to make it inefficient. By not letting it work together with each other, by having walls up in between, by having rules that say you can only go here, you can only go there. You're a poor Native person running down in the lower 48, you're lucky to find any place to get health care. You have to run into maybe an urban organization or kind of a receptive tribal one if you live there long enough. So one of the broader missions of Indigenous Pact is not only to create equity and increase resources, but also to make better use of the resources we have. We're looking at potentially kind of a nationwide insurance program for IHS and tribal caregivers, so that one day, could you imagine if you had a tribal health card and you could use that anywhere, like as if you were Blue Cross Blue Shield, and nobody would feel bad about it, that you would actually make, it would be better for your system if you did it. So that's a vision that we have. And I don't know how we get there. We have to convince people that it's a worthwhile one, but it has to break 100 years of history of developing healthcare based on kind of a castle attitude, building the walls up and allocating the scarce resources inside of it, like we're trying to, save the few pigs and waters that you had there or something, instead of trying to, create more. So that's something that's the larger vision, is to create an integrated network that can provide higher level of healthcare to more people using the system and using all of the efficiencies we can, and that have already been developed in it, sometimes sub-regionally or regionally.
No, thank you for that. And that's why it's so important to have people and organizations like Indigenous Pact to lead the way, to break the mold, and to bring out ideas, because sometimes the solutions are right in front of us, but we don't have the team or the manpower to get it going. But you guys seem to be on the right path. So thank you again for taking the time to sit with us and talk about the amazing work that you guys are doing and the challenges and opportunities that Indian country has. We want to thank our listeners for sitting in with us another week and listening in and joining us today. And we hope you enjoyed today's episode. And as always, thank you for listening to the Hoporenkv podcast. Now, if you enjoy our show, please make sure to like us and rate us on Apple Podcasts, Google Podcasts, Simplecast, Spotify, and visit our website, www.nativelearningcenter.com, to find information on upcoming webinars, virtual trainings, and more Hoporenkv podcast episodes. So thank you, everybody, and we will see you again next week.